Hello, this is vs.noncoronary. I would like to present to you an important cardiology article recently published in the New England Journal of Medicine. As we know, COVID-19 often involves the respiratory system. However, cardiac involvement is also common. We often see EKG abnormality, including ST changes in these COVID-19 patients. We frequently encounter situations where emergency decision has to be made whether these ST changes, including ST elevations, represent ischemic injury or not. So this case series tries to highlight the early experience in the United States about the clinical features in COVID-19 cases, including their symptoms, risk factors, EKG features, echocardiogram, and angiographic findings, and most importantly, the outcome, that is the mortality among patients with ST elevation noted in their EKGs. Therefore, this case series will certainly be a valuable addition to our knowledge base. I am a cardiologist practicing in South Central Pennsylvania in the United States. I have no financial disclosures for this presentation. This is just a review of a published article for general awareness as well as awareness for cardiovascular healthcare workers. I think this is a very important paper for us cardiologists as well as anybody working in cardiovascular medicine, because we'll often encounter patients with COVID-19 issues, and the question is whether to take them to the cardiac cath lab to manage as acute coronary syndrome or to manage as carditis is always an issue. So this is a timely published paper. I think we should appreciate the work of the authors from New York City, Dr. Sripal Bangalore, Judith Hockman, and other cardiologists. So this was a case series of only 18 patients, a small study, but all of them had ST elevation in their EKGs. The median age of the patients was 63 years, and out of 18 patients, only 3 were females, but most of them were males. Very important finding. I think it has been reported similarly in other papers from China and Italy as well. These were the underlying cardiovascular risk factors in 18 patients. 65% of them had hypertension, 41% had hypercholesterolemia, 35% had diabetes, about 1/5 of the patient had known coronary artery disease, 6% had history of smoking and chronic kidney disease. These are the main clinical symptoms of these patients with ST elevation in their EKGs. Only 1/3, very important to note, only 1/3 of the patients with ST elevation in their EKGs had chest pain. Most of them had fever or respiratory symptoms, and 2/3 were intubated, 39% were in shock, and 11% had presented a cardiac arrest. Now let's learn about the EKG changes in these patients. Out of 18 patients, 10 had ST segment elevation in their EKGs at the time of presentation, but almost half, the other 8 of patients, developed ST elevation during hospitalization over median 6 days. So what were the EKG features of ST elevations in their EKGs? It's important to note about 20% of patients had diffuse ST elevations, like when we think of global ischemia, like in left main or 3-vessel disease, but about 80%, 78% to be exact, had focal ST elevations when we think about single arterial territory ischemia. About 17% had anterior ST elevations, 44% had inferior ST elevations, and 50%, the majority of them, had lateral ST elevations. It seems like some of the patients had inferior as well as lateral ST elevations. What were the echocardiographic findings? Out of 18 patients reported in the case series, 17 patients had echocardiogram completed in their report. Almost half of the patient had normal ejection fraction. That means normal left ventricular function. Very important finding to note. And 53% had low ejection fraction. So low ejection generally means ejection fraction less than 50%. And 35% had regional wall motion abnormality, and 18% had just a global hypokinesis. No regionality was noted. Important feature for us to note. So how many of them actually underwent left heart catheterization? So these are the patients with ST elevations, clear-cut ST elevations on their EKGs, COVID-19 patients. So it appears that only 50% or 9 patients out of 18 were taken to the cardiac cath lab for left heart catheterization and coronary angiogram. Out of 9 patients who had cath completed, 6 were found to have obstructive coronary disease, which is by definition more than 70% blockage in one of the 3 major arteries, or more than 50% in left main. And out of 6 patients who had obstructive CAD, almost all of them, 5 patients underwent percutaneous coronary intervention, and one of them looks like had lytic therapy first, and then underwent subsequent PCI. All these patients had chest imaging completed, either a chest X-ray or CT scan. The important finding was that in patients with ST elevations noted in their EKGs, there were bilateral infiltrates noted in their lungs in 78% of the cases. So majority had bilateral pneumonia, or at least chest infiltrates. And focal opacity was rare. It was noted only in 6% of the cases, whereas 17% of them had, interestingly, normal chest imaging. What were the main laboratory findings in these patients? The peak troponin I was 44 nanogram per ml. The peak troponin T was 4.4 nanogram per ml, and D-dimer was 858 nanogram per ml. These were the median values. And importantly, all these 18 patients, so 100% of them, were found to have elevated D-dimer levels. So how was non-coronary myocardial injury defined? Those patients who had echocardiograms, normal left ventricular function, and no regional wall motion abnormalities were presumed to have non-coronary myocardial injury, and they were not taken to the cath lab. Among those 50% or 9 patients who underwent left heart catheterization, so 3 of them had non-obstructive coronary disease, and they were also obviously put into the category of non-coronary myocardial injury. The total prevalence of non-coronary myocardial injury was higher, about 55%. That means 10 out of 18 patients. An acute myocardial infarction due to ischemic injury was present in 8 patients, or 45% of them. And it was noted that patients with acute myocardial infarction or ischemic injury obviously had higher troponin levels, but they also had higher D-dimer levels. Now this slide is very important. Let's learn about the outcome or the mortality of these COVID-19 patients with ST elevation noted in their EKGs. Out of 18 patients, 13 or 72% died in the hospital. and most of the patients with non-coronary myocardial injury died. So based on the prior slide, there were 10 patients with non-coronary myocardial injury and 9 of them died. So non-coronary myocardial injury was associated with much higher mortality. In contrast, from the prior slide, there were 8 patients with acute myocardial infarction and there was 50% mortality, or 4 patients died in this group. Now it's not clear to me how many patients, those who survived, had revascularization or PCI completed. So what does this suggest? There is a high prevalence of non-coronary myocardial injury and associated risk of mortality. Now this was a very nice paper explaining the clinical as well as laboratory imaging and coronary angiogram features of these patients with ST elevation noted in their EKGs. I think this paper will have some limitation in terms of the acceptance of definition of non-coronary myocardial injury, which was presumed based on normal ejection fraction and normal regional wall motion, and half of them didn't undergo left heart catheterization based on that. The true prevalence would have been found if all of them had undergone left heart catheterization. Now in clinical practice, we know many patients with STEMIs can have normal EF and normal regional wall motion also. The other thing I noted, the authors did not report how many of them had reciprocal ST changes. Whether that guided their clinical decision to take to the cath lab is unclear to me at this point. D-dimer levels, all of these patients had elevated levels, and it's not clear why. Maybe they had some other inflammatory processes on these patients, because the Chinese paper on purely STEMI patients had reported 64% or majority of them had normal D-dimer level. Obviously, this is a great asset for our knowledge base, and future retrospective and prospective cohorts will provide us more description, understanding about these patients. Thank you for watching this presentation. Please don't forget to write your comments or suggestions below. Thank you.